his belongings, put them all in the apartment complex, and slept outside under the stars because he was connected to. And this is true. It's a real story. This is a real story. And his energy level was just like, and the thing is we ended up treating him, he ended up really getting better, and he was getting ready to go off to school on the East Coast. And so he had a year that he had to get well, get healed. And so at the end, we were able to have this conversation with him about what are your triggers? So cannabis, staying up late, you don't need to cram. I need you to, we need you to, study ahead of time, because staying up all night and drinking coffee all night long, while some of us could do that and recover, not for you. So these are the kinds of psychoeducational things that it's really important to help kids know, and families, how they can sort of help themselves. So educating the family, educating the kid, again, especially when you're dealing with kids. Special education services is huge. You want to set these kids up for the best possible. Getting an education is an important piece. So family-focused therapy can be really helpful in terms of, how do we increase communication and educate families and kids. Interpersonal and social rhythm therapy, this has to do with stabilizing routines and sleep-wake cycles. Interpersonal relationships are really important. It's an important part of the development of adolescence, and it's an important piece of what can sort of help people stay well, is having people that they can talk to and can take care of them. So that's an important piece. It can be hard for kids who are in foster care who are moving around a lot, which is why it's even more important if there is someone who can travel with them or be along, that road with them.
I have heard with bipolar that crossing date lines is a tremendous trigger, that there's something back to
the circadian rhythm can, yes, yeah.
Which is back to the sleep.
Yeah, yeah.
Sleep disorder.
The question of whether or not it's a sleep disorder itself, or whether just getting your circadian rhythm off, can sort of be a triggering factor for a manic episode. So sort of similar to if you think about how you educate people about how to keep them if they have migraine headaches, right? Making sure you get enough sleep, not taking too much caffeine, those sort of things. So what kind of pharmacotherapeutic interventions? So here are all of the agents who are, the EMA is the European Medical Agency, that are approved for the treatment of bipolar disorder. So if you look at this, these medications here, olanzapine, risperidone, quetiapine, these are atypical antipsychotics that are approved for acute mania, as well as maintenance. So that means once you're stabilized on your medication regimen, this is sort of what keeps your mood stabilized so that you don't go into those opposite extremes. And then you have other medications as well that are anti-epileptic medications. This is a large list for everyone, for adults. This is for kids. So we have the medications that we've already talked about, the antipsychotic medications that we've talked about. The age here goes down to 10. And then we have lithium.
They still use them.
Lithium is a miracle.
Really?
Lithium, I'm telling you, for the kids that I have that really are ill, pediatric bipolar disorder, the adolescent, the youth that I was describing earlier who did end up really getting better and going off to school on the East Coast, lithium.
Really?
I mean, it has been.
Does he have to continue to take it, or is this for that certain period of time that it was prescribed when he was having his symptoms?
So let's go back for a second. I'm glad you asked that question, and I'm not trying to put you on the spot, but, and I will say, this is the thing to keep in mind. This is chronic. This is a lifetime. We're not, we're not curing bipolar disorder. Yes, you have to keep taking it. That's an important piece. You guys, you have to know that.
So nobody has ever gotten over being this diagnosis?
No. We're not curing, we're stabilizing episodes.
It's like treating diabetes.
Exactly. We are not curing.
Type 2, but not type 1 you can. Not type
Same kind of thing, it's the same thing.
You guys, you have to be the clinicians that carry this. You have to carry this.
I think what's one of the hardest things that I've had to deal with my son is that denial of the patient, and that's so common with schizophrenia, and I don't know if that's also common with bipolar disorder, is that I'm not sick, or I'm taking my medicine, I felt better, I've been taking my medicine for a few months.
That lithium, here's the thing too, is that lithium has been shown to have neuroprotective factors. So I think it's very interesting that,
Okay,
so.
This guy had everybody, it was at the Claremont, and they packed the room, and everybody walked out just after a full day.
What was the talk about? Was it promoting some other drug?
That's a really good question. It was through I'll email you.
Yeah, it was probably.
I'll email you the name of the guy.
Yeah.
Because he pops up all the time.
Yeah.
And it was really disheartening.
Yeah. So, just for the sake, so let's just run through this with lithium. So, lithium is a salt, right? So it's an element, and so I love these kind of things. But so lithium inhibits excitatory neurotransmitters. So let me just say this before we even go into these slides. We don't really know. Like, we know some of what lithium does. We know we know how they impact the cellular level. But sort of like ultimately, and we can sort of hypothesize then how those things can then impact the brain and what we see in terms of stabilization, right? But like really absolutely knowing to the T, no. But what we do know, and here's the thing that you guys should remember throughout all of this. Too much excitement on a cellular level in the brain causes problems, okay? And you see it with crack, you see it with amphetamines, you see it with too much ecstasy, you see it. So part of the role in a lot of these medications has to do with trying to inhibit some of this excitatory neurotransmission. And that is what in promoting inhibitory transmission. So that's sort of what the whole concept is around, treating the manic episodes. Predictors of good lithium response: positive family history of bipolar disorder, previous remission with lithium, and classic euphoric manic episode. So basically what this is saying, that if you really have bipolar disorder and have had and you really had a manic episode that is true mania, lithium works really well. So that's not exactly. And if you have like bipolar disorder that some person that didn't really go by the criteria just diagnosed you with, or you have mood disorder NOS or blah, 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 that's not. But if you really have bipolar disorder and have really had a manic episode, lithium is a fantastic medication for you.
Forever? I don't mean you have to take it forever.
I was like, I'm done. I was like, I'm leaving.
Work for a period of time. It could be 10 years, and they stop working, and drugs have to change it.
Sometimes, I mean, yes, the thing is,
I know you have to take it.
yeah, I was gonna leave and take my plant and leave. No. But yes, I mean, I think that we're just remembering that there's a chronicity to the diagnosis, right? And so that there may be like episodes that come despite medication compliance and where medications may need to be adjusted. So yes, yeah. But, like if you go back to this slide, it's like previous remission with lithium sort of, insinuates that maybe you stopped taking it and then, yeah. So the important thing is that I love this because this is a great way of, this is a way a med student drew this to remember like how to, what the side effects are, but there's a narrow therapeutic index. So monitoring is really important, right? Because this is one of those medications that you can draw a level. Brenda, this is your kind of medication. Right, you do draw a level and there's a therapeutic index. So if you draw a level between 0.6, 1.2, you know that you're in a therapeutic window. But if you get beyond 1.2, then you start to be thinking about lithium toxicity, which I don't think I made a slide for that as I'm thinking about. So common side effects being common. Seizures are not common, but they are serious. Thyroid issues are very common. Thyroid issues, tremors, weight gain, these are all sort of very common things. Weight gain, tremors, hyperthyroidism. We check those. We check your kidneys, which is why those are common things that can be impacted. Why? Because lithium is actually one of the few medications that's actually excreted through the kidneys instead of the liver, metabolized through the kidneys. So, these are important things. You know, we're talking about adolescence, so knowing that it's very teratogenic is an important thing too. So those are sort of common things associated with lithium. So what's the recommendation then? This is one of the medications, and it's the only one that we've talked about so far, where you need to have a level. You need to check a lithium level on a consistent basis. You monitor it closely at first, every the first few days. And so usually what I'll do is I'll have a patient start the medication once I get to the dose that I want them to be on. I have them take it for a week, and then I get a level. Okay?
So
Why?
Run up, then there's a week of stable dose per day, and then you take a level.
Yes, right.
So do we know more or less what the total amount of time is before you take your first?
Well, I guess let's just say this. Once you get to the dose that I'm starting you on, that I think you're going to stay on for a little while, take the medication for 7 days, because it takes about that amount of time to get to steady state. And then you monitor it every 6 months. So once you've been on it in the first year I usually monitor every 3 months, and then after you've been on the medication, monitor it every 6 months. And you want to monitor renal function, because again, it's excreted through the kidneys. So you want to make sure that there's an okay renal function. Now this is important because like if you have problems with your kidneys and your lithium level could be too high because it's not getting excreted, so this is important. These are things, thyroid, renal function. I don't typically do parathyroid, but you can do that as well. These are things that we are monitoring at least, twice a year after we've got to a point of stability. If you have a child that's on lithium and you never see any labs, that is a problem. That's a problem. I've seen it happen, but that's a problem. And you're monitoring weight as well. So these are some things that, have I ever said anything was a contraindication? I don't think so, but there are some contraindications, like severe renal problems, that's a contraindication to lithium treatment. Why? Because you can become toxic, lithium toxic. Severe cardiac problems. These are relative, but the only renal failure and like history of MI are the absolute contraindications. But these are things that you want to be concerned about. I mean, pregnancy, no, like we just don't. Unless you just have really had extremely severe, and then you're really, I would say even ECT is probably better than that. But these are some things to keep in mind. I think this slide says about the same thing here. The thing this is where it becomes a little bit important for us so volume depletion. So again, there's a narrow therapeutic index. You want your lithium level between 0.6 and 1.2. So if you're starting to get dehydrated, then your lithium level can then increase substantially. And so that's one of the things, we talk about psychoeducation, that we would want to know. The dehydration risk is huge, and that people understand the importance of staying hydrated. Understanding if there's a family history of thyroid disease and monitoring for that is also important. So Depakote is not indicated for kids. However, it is a medication that's commonly used in bipolar disorder for kids. And a similar, so inositol is a hypothesis, and you could find literature to say that this is a hypothetical theory as to why lithium works for bipolar disorder. Is that again, if you think about what these medications are trying to do, what inositol does is it really kind of helps with on a cellular level with gene expression and signaling that occurs between different cells in the brain. And so the idea is that something becomes off, and that inositol is just sort of overactive and sort of over signaling, and that's what lithium is and Depakote are sort of doing as well. Similar situation here with voltage gated sodium channels. So Depakote acts on calcium and sodium channels and GABA. So again, the idea is that we're just sort of like trying to inhibit this overexcitatory phenomenon that's going on in the brain.
So if you give someone GABA as a supplement, would you see a behavioral response?
I can say that I have not seen that with bipolar disorder. I've had people experience the feeling of a decrease of anxiety with GABA. GABA is an inhibitory neurotransmitter, so it tends to be calming. Depakote is used for seizure disorders. This is an important clinical pearl. Women of childbearing age, you just really don't want to prescribe it to women of childbearing age, lithium or Depakote. These are not medications that you would want to be prescribing to women of childbearing age. So again, you can start to see differences within a week to 2 weeks with the initiation of Depakote. And then, lithium, Depakote, these are where pregnancy tests really do become like super important in monitoring blood work. So thrombocytopenia and platelet dysfunction, so that's where we're getting our monitoring for our CBC and liver function. These are common side effects. Nausea, vomiting, weight gain, liver function, so transaminitis, sedation, tremor, hair loss, very common with Depakote. Mm-hmm. And here's our picture. So the alopecia, thrombocytopenia, the bleeding, hepatotoxicity, pancreatitis. So these are common things to be thinking about when you're talking about lithium. So what do we want to be monitoring? Liver function. You want to get these things on baseline, and then twice a year. And let's talk about our case. Any questions?
So what do you do if you have a patient who's doing well?
Chief complaint, mood problems. Adam was diagnosed with bipolar disorder at the age of 5 after he experienced a manic episode that included months of insomnia, irritability, and giddy mood, aggression, and psychosis. He was having visual hallucinations of bugs crawling all over him and his mother, and he was extremely paranoid. Prior to that, he was on medication starting at the age of 3 for insomnia. Over the years, despite medication, and I would add numerous different medications, Nicholas has had similar episodes described above without the psychosis, though. At baseline, his baseline includes frequent tantrums with little provocation, but last month, patient's medications were changed by an outside provider because of an increase in irritability over the summer, causing him to be kicked out of 2 daycares. He's reportedly throwing things, hitting peers. Adderall and lithium, Lamictal were added, which mother feels have been helpful, insisting the patient to stay still, more focused on his homework, and better able to concentrate. And there were no reported side effects. So that paragraph describes my his initial presentation to me. And I've seen him now, I no longer see him, but I saw him for a number of years. And over the years of treatment, he was admitted to inpatient hospitalization. He had multiple inpatient hospitalizations for acute manic episodes that included severe insomnia and irritability. He would become sexually provocative in class and verbally abusive and assaultive to his mother. At one point, she presented with physical bruises on her face and arms after being physically assaulted by him. During each hospitalization, his medications were changed due to manic symptoms, and he was eventually transferred to a higher level of care from being treated by me. The medication regimen that he left me on was Abilify, 15 milligrams twice a day, lithium 600 milligrams twice a day, clonidine 0.05 in the morning and 1 at night, and he was on metformin 500 milligrams twice a day. And you can see the long list of medications that he had tried in the past. And he had been in therapy since preschool, and he was in a special day class at school. He'd never attempted suicide, but he had engaged in self-injurious behaviors like hitting himself, slapping himself, and he does have a history of physical aggression. At that time, the psychiatric hospitalizations, he had not had any by the time when I first saw him at the age of 9. And that was a huge problem when he did need to be hospitalized because he was so young, and finding a hospital in this county that takes 9-year-olds is virtually, we don't have any beds in our county for kids under the age of 12. So he ended up having to go to Contra Costa. He lives alone with his mother, who's a nanny. And this was, I thought, an interesting piece, is that he was in foster care around the age of 5 when he was first diagnosed with bipolar disorder. And he was diagnosed by a physician, a child psychiatrist at Children's Hospital, who was actually really well known. And she started him on medication. And CPS, his aunt called CPS because she felt that it was inappropriate for him to be on medication at that age, and that it was inappropriate for him to be diagnosed. And so he was actually away from his mother for weeks because of that phone call. They had to investigate the validity of his diagnosis. Yeah. Yeah.
Wow.
He has and so he was off medication during all of that time and had severe behavior problems while he was in foster care. He did not go to his aunt's house. Yeah.
You got that?
Right.
I couldn't believe it. The mother had severe depression. As a matter of fact, had to have ECT while she was pregnant with him, the severity of her depression. And there was and the father had bipolar disorder, and there had been a long family history of mental illness. And so, he has no medical problems. The mother was exposed to opiates when she was pregnant with him. And she received ECT. He does have speech delay, and had OT from some other sort of mild motor skills deficits. So these are the kind of cases. This is a very sad situation. This is a child who was really heavily genetically predisposed to have mental health disorder. He had a first-degree relative, both first-degree relatives, both his mother and his father. Mother had severe depression. Father had bipolar disorder, were mentally ill. And he had struggled with, his mother was exposed to medication while she was pregnant with him. And so he has, from a very early age, struggled significantly with his behavior at home, at school, as well as his cognitive ability in classes. This is a person who has a true, and it's interesting because I remember I had a nurse practitioner intern that was working with me during the time when he became during one of his manic episodes. And at that time, he may have been 10 and a half. And she was a really cute nurse practitioner, intern. And so, and this is an example of how the kind of grandiosity and when you're becoming manic, and he in the hypersexual sort of, and he was flirting with her in the session. And she was, he was like, "You look really nice today." He's 10 years old, and she was like, and we had to debrief afterwards, and she said, was he flirting with me? And I was like, yes. And what does that tell you, right? And so it was an example of the kind of the sort of mood and this kind of grandiosity and hypersexual sort of feeling that one could get. Your average 10-year-old doesn't like hit on the nurse practitioner that comes on to. So this brings up a number of different things. So the other thing I want to point out here is that he's on metformin. He's on metformin 500 milligrams twice a day. He does not have diabetes. And the important thing, one of the things that I didn't touch on, but that's one of the ways that we sort of try to deal with the weight gain and the potential metabolic side effects related to antipsychotic medications, is when you start to see kids start to put on weight, is that adding something like metformin, even if they don't have a diagnosis of diabetes, can be really helpful. Not necessarily making them lose weight, but it can be helpful. Buffer against more increase in weight gain and then the potential glucose side effects. So what I want you to focus on is his current psychotropic medication regimen and not his past, because it's too lengthy, as we answer the next questions related to his labs.
Would the ECT have caused any issues?
ECT is actually, you know, especially if you don't have to give, I mean, well, you do have to give, I mean, the biggest side risk of the ECT is less related to but it's the medication, it's the induction, yeah. We want to take, we don't have time. I would say take a break, but we have to work. Okay, so we're gonna looking at his current medication regimen. What would we be wanting to add to the monitoring that we would be doing that we've already talked about with his Abilify? We already know the kind of monitoring that we would want to be doing because he's on Abilify, but what else would we want to be looking at because of the rest of his medications?
Isn't necessarily that we get everything correct, although it feels good to get everything correct. But it is that we recognize more than anything the importance of, you know, like how complicated these particular cases can be, right? And how much energy and thought has to go into sort of what we're looking at and what needs to be monitored. And I would just encourage you to, you know, continue to look at cases in this way and just to continue to be thinking about it. So we're going to start with this group first. What labs, what frequency, what measurements would you want to monitor? What other measurements would you want to monitor, given that we haven't talked about?
We started by saying this is a lifelong
We got that.
Okay. I can go home now.
Okay, so baseline labs, and then looking at levels after 7 days, and then at 3 months, and then at 6 years, and then 6 months after that, right?
Correct.
Renal function tests every 6 months, thyroid tests every 6 months, and then electrolytes, codifiber, and weight annually. And then the final thing is blood pressure check, but we didn't, I don't remember.
That is correct.
Let's
That is
see
correct.
blood pressure check, quantity.
Yeah. You would want to, I mean, typically I would try to monitor blood pressure on every
Every
visit.
visit.
Yeah.
Yeah.
And I think that's fantastic. The only thing I would add to the lithium that I didn't say before is that if you have a reason to believe that a child is having symptoms of lithium toxicity, which would be blurry vision, problems with coordination, pain, those sort of things, then we would check the lithium level even if it were in between that time. Excellent. Yeah.
Contraindications really when you have cardiac issues. And lifestyle, sleep, hydration, psychotherapeutic interventions, and of course, if you make sure you're taking the medication regularly as
Right.
prescribed.
Absolutely. And so I think the great point about adding in the contraindications about renal or cardiac would be, you know, assessing that history, that family history, to make sure that if it's not documented in the chart, the physician record, that it's something that you have asked about and you can update the physician about. Did anybody have anything else that they would add to the monitoring, either related to the labs, the lifestyle habits, or other pharmacologic interventions? I'm sorry, the labs or other lifestyle habits? I thought you guys had some lifestyles.
Usually the same ones that Lori said, basically adequate sleep and adequate hydration.
And I thought I heard one of you say something about school.
Oh, yeah, actually under non-pharmacological intervention, school, just making sure that they have an IEP or whatever, yeah.
Correct. Right.
Yeah. And also education of the patient and the family is very important, and then therapy.
Yes. One of the kinds of therapy that can oftentimes be helpful for kids who are having a lot of difficulty at home, and if you feel like there's a parenting piece or a behavioral modification piece that needs to occur in real time, is TBS, Therapeutic Behavioral Services, where you have a therapist that goes to the home and helps. He did have that as well.
Oh, good.
Yeah. Did you all have any other things to add in terms of what other pharmacologic interventions? Yes.
Well, the self-monitoring piece to develop insight. So any kind of metric tracking and correlation between mood and circumstances, environment, behavior patterns like sleep, food, deficits, or, any of that thing. How does that turn into an insight process?
Right. That's a really good point. And so mood charting is a really helpful way to help patients track their mood. And typically, there are apps that you can get on your phone where it sort of tracks your mood, your sleep, you can track what you've eaten that day, that exercise. It can really give you a sense of like what sort of triggers may be changing things and that sort of thing.
Do you have any favorite app?
Do you think his age would be?
He might need some help with his mom, yeah, from his mom.
I love that mood charting. I
If
forget the
you're in the
one.
mood to do it, it's great.
Right.
Right.
So, that is all I have, guys.
That was fabulous.
All right, and I'll collect the evaluations.
It's okay. I think we actually solved the problem. It was just kind of late. But you did good.